Hello and welcome to Med Tutorials. This is your place for simple and easy to follow tutorials in internal medicine. Today is going to be level 5 in the series titled Decoding the ECG. What do you do when you're presented with an ECG? You may be a student in an examination, or you may be a medical personnel in a life and death situation. And there you are, you're presented with this ECG. How do you approach that ECG? What are the steps? Today we're going to be looking at the 12 steps we need to follow when reading an ECG. Especially if you're a beginner, it's important that you read the ECG in a stepwise manner so that you don't miss out on important findings. In this tutorial, I'll be showing you the 12 steps and we'll be spending some time on each of these steps. And at the end of the tutorials, we're going to put these steps into practice and we'll try it out on some trial ECGs so that you get some confidence in reading the ECGs. So let's get started. So as we head into the 12-step approach to ECG interpretation, I would just like to tell you that I won't be covering the basics, and I've put the links below to the previous 4 levels. And if you'd like to go deeper into the basics at any stage, you could access those ECGs tutorials below. So I'll start by listing out the 12 steps that we follow in ECG interpretation. We start with calibration, then the rhythm, rate, axis, the Pwave, the PR interval, then we look at the QRS complex, the progression of the R waves, the ST segment, the T wave, the QTC interval, and finally the U wave. So if you look at an ECG, generally we move from left to right when we interpret an ECG. So we're going to start with calibration, then we're going to look at rhythm, and then the rate. Now there are some people who do rate before rhythm, but I prefer rhythm before rate because depending on the rhythm, you're going to use a different method to calculate the heart rate. Followed by that, you look at the QRS axis, and then the next step is to look at the P wave, the PR interval, the QRS complex, and associated with that you look at the progression of the R waves, and after that you're going to look at the ST segment and the T wave, and then the QTC interval, and finally the U wave. So vertically we measure the voltage in an ECG. Here we have a standard calibration where 1 millivolt is equal to 10 millimeters. Now sometimes in an ECG you might have a calibration that is made probably to a half calibration or quarter calibration, or maybe even a double calibration depending on the need in an ECG. Sometimes the machine automatically changes the calibration so that the ECG complex can fit into the ECG paper. Now I'm going to show you the importance of looking at calibration. Now if you look at this ECG, you have the same lead 2 which is in the first line and in the third line. So it's the same lead, but if you look at the complexes, they look quite different. Now look at the calibration bar. In the first one, that open rectangular calibration bar looks larger than the one on the third line. This is because the first line is a standard calibration, whereas the third line is a quarter calibration. And based on that, you can see the difference in the size of the complex in the first line and in the third line. So if you ignore the calibration, you're going to have a misdiagnosis of voltage related diagnosis. Like for example, you could underdiagnose or you could overdiagnose a low voltage complex or even chamber enlargement if you ignore the calibration. So second step we look at is the rhythm. Now we need to observe regularly the QRS complex. How does it appear? Is it regular? Is it appearing regularly? Is it appearing occasionally irregular? That means you have a lot of regular complexes and then you see one complex which is appearing irregularly. Or is it regularly irregular? That means you have a pattern in the irregularity. Or fourth, is it having no pattern at all? Is it irregularly irregular? And we'll show it in the next slide where you look at the ECGs. Here you see a normal ECG where you see the QRS complex is appearing regularly. Now look at this second ECG. You see that the first two are regular and then there is an irregularity. This is what we call occasionally irregular. Now in this third ECG, we see that the irregularity is occurring at regular intervals. And this is what we call regularly irregular. And what about this fourth ECG? If you see, they're all coming at different regularities at different periods. And this is called an irregularly irregular ECG. So the third step is that you calculate the heart rate. Now, as I said earlier, depending on your rhythm, you're going to use a different method to calculate the heart rate. Now, most often you're going to use a big square counting method, which is the easiest method to use. Sometimes you would use a small square counting method, and rarely you might use a QRS counting method. So coming to method number 1, big square counting method. Here you count the number of big squares in the RR interval, and you get the heart rate by 300 divided by the number of big squares. So in this case it would be 300 divided by, you could take it 4, and you would get an approximate heart rate. And this is the easiest method that we use. Sometimes if you want to calculate the heart rate more regularly, or if it's a very fast heart rate, then you could use the small square counting method. Here you count the number of small squares, and the heart rate is derived by 1500 divided by the number of small squares. Now, as I said earlier, in case you have an irregular heart rate, the above two methods might not be that accurate. So we use the QRS counting method, which is a little more tedious, but it's useful for irregular heart rates. So here the average heart rate is counted. You count the number of QRS complex in a fixed time interval. For example, you could take 30 big squares, and if you know the calculation, 30 big squares is 6 seconds. So you get the number of QRS complexes in 6 seconds. You multiply by that by 10, and you're going to get 60 seconds, 1 minute, and you're going to get the heart rate. So there are two methods to determine the axis. You have the longer method and the shorter method. The longer method is more accurate, but you need to know the orientation of the peripheral leads. And I'm going to show you a diagram, and I've done this in the previous tutorials, and we need to memorize the diagram of the axis where each lead, which is the predominant direction in which it points towards. Of course, you have a shorter method which is much more faster but might be less accurate than the longer method. So this is the axis chart that we need to memorize to know where each lead is pointing towards. We see that from -30 to +90 is going to be your normal axis, and that's from your lead AVL right up to AVF. Of course, from AVL to -90 is left axis deviation, and AVF to +180, that is +90 to +180 degrees, is your right axis deviation. And what's in between +180 and -90 is your extreme axis. So if you have an idea of this chart, you will be able to accurately assess the mean QRS axis of the heart. So this is how we use the long method. There are certain rules that we need to apply, and when we apply it along with our knowledge of the chart, we'll be able to assess the QRS axis. So rule number 1, the mean QRS axis is in the direction of the lead with the tallest R wave. So if you look at your ECG, which is the lead with the tallest R wave? You can see it's lead number 2. So applying this, we can derive that the mean QRS axis is in the direction of lead 2, and that's plus 60 degrees. And so you can use now these following rules which I'm going to mention to sort of reinforce that yes, the axis is definitely in plus 60 degrees. So you're going to use rule number 2. The mean QRS axis is midway between two leads with equally tall R waves. Now if you look at this ECG, you have lead number 1 and lead number 3 which have two equally tall R waves. And if you look at your chart below, we see lead number 1, that's at 0 degree, lead number 3 at plus 120 degree, and so midway would be lead number 2 with plus 60 degrees. So you're reinforcing your diagnosis that the lead, your derivation that 2 with plus 60 degrees is the axis. Now the third point, the mean QRS axis is perpendicular to the lead which has an equiphasic QRS complex. Now if you see AVL has an equiphasic QRS complex, that means the positive and the negative. That means the R wave and the S wave are of almost equal height. So in the chart we could see AVL is perpendicular to plus 60, that is to lead 2. So again you're reinforcing your diagnosis, your interpretation that the QRS axis is plus 60 degree. And we also have this rule that mean QRS axis is usually opposite in direction to the lead with the deepest S wave. So if you see the deepest S wave is in AVR, and again it's in opposite direction to lead number 2. So from this we could accurately say that the mean QRS axis is going in the direction of lead 2, that's plus 60 degrees. Now you have a shorter method because when you are assessing an ECG, you might not have all that time to go into details to look at the axis, as you have to look at other things as well. So here you look at QRS complex in lead 1 and AVF. Lead 1 and AVF. Now if you have a taller R wave in lead 1 and a deeper S wave in AVF, they give the appearance that they are leaving each other, and leaving each other is left axis deviation. It's easy to remember, L for leaving, L for left. Same time, if you have a deeper S in lead 1 and a taller R in AVF, they appear to be reaching each other. So again, it's easy to remember, R for reaching, R for right axis deviation. And if you have both a predominant positive QRS wave in both lead 1 and in AVF, you take that as a normal axis. For example, if you see in this ECG, you have lead 1 which is pointing upwards, and that's a tall R wave, and you look at AVF, you have the ECG again, it's both pointing upwards. So that looks like a normal axis as they are both predominantly positive. So we're going to look at some examples of short method. In ECG 1 we see 1 and AVF. 1 is predominantly positive, AVF is negative, and so they looks like they're leaving each other. So as I said, leaving each other equals left axis deviation. L for leaving, L for left axis deviation. Now in ECG 2, if you look at 1, it's predominantly negative, whereas AVF is predominantly positive. So it looks like they're reaching each other. Reaching each other equals right axis deviation. R for reaching, R for right axis deviation. Now in this ECG we see that both 1 and AVF both are predominantly positive, and so they're neither leaving nor reaching, and this is an example of a normal axis. Now what do we observe in the P wave? We're going to observe all the P waves, but we're going to pay special attention to leads 2, AVR and V1. We're going to measure the P wave, the width. Normally the width is less than 0.12 seconds and the amplitude is less than 2.5 millimeters. We're going to look for the pattern of the P wave, Sometimes the P wave might be absent. You might not see any clear P waves. And for example, in atrial fibrillation, you're just going to see an undulating baseline. Sometimes you might see variations in the morphology of the P wave in the same ECG, different P wave shapes. For example, in atrial premature complexes, you might have few complexes which have a different morphology. Sometimes you have P waves of characteristic morphology which might give you a clue as to atrial enlargement. Now take a look at this ECG. If you look at the P waves, you see that they are of different shapes. This is an example of multifocal atrial ectopics, where the P waves are not originating from the SA node, but rather they are originating from different points in the atria. Take a look at this ECG. We don't see any clear P waves, but what we see is an undulating baseline. It's not a flat baseline, but it's a fibrillating atria. And this is the example of atrial fibrillation. Now, as I said, you can have certain specific morphological patterns which might give you an idea that it might be right atrial enlargement or left atrial enlargement. So here we are going to focus on lead 2. In right atrial enlargement, you can have tall, narrow peaked P waves in lead 2. And this term is sometimes called P pulmonale. In left atrial enlargement in lead 2, you can have prolonged bifid P waves, or sometimes called a notched P wave in lead 2. And in lead V1, you can have a biphasic with a predominantly negative phased P wave. And this is termed as P mitral. Now here's an example of P pulmonale in a ECG. You see the narrow peaked P wave in lead 2. So what do we observe in the PR interval? We're going to measure the interval. Now the normal interval is 0.12 to 0.2 seconds. That's 3 to 5 small squares. Short PR interval is one of the examples is Wolff-Parkinson-White syndrome, and long PR interval is seen in first degree heart block. We also have to keep in mind to look for PR intervals that they are same in all the complexes and they are not varying in their duration. What do we observe in the QRS complex? So normally the width is less than 0.12 seconds. The broad QRS complex could be suggestive of a left bundle branch block or a right bundle branch block, and we'll be seeing that in later tutorials. And if you have a patient with tachycardia, the QRS complex is extremely important to differentiate ventricular from supraventricular tachycardia. Then we look at the amplitude. This helps us to look for low voltage complexes, or higher amplitude is useful in diagnosing left ventricular hypertrophy. In older individuals, we could use this formula where we calculate the amplitude of S wave in V1 and the R wave in V5 or in V6, and if the total is more than 35 millimeters, it might be an evidence of left ventricular hypertrophy. We also look for characteristic patterns, as I was telling earlier, specific bundle branch block patterns. We look for significant Q waves, and this is to localize the areas of ischemia. We look and see, is it in the inferior leads or is it in the anterolateral leads? We need to remember that not all Q waves are abnormal. Some Q waves may be normal. Septal Q waves can be normally seen, but remember that they are narrow, less than 0.4 seconds, and that's one small square, and they are seen in leads 1, AVL or V4 to V6. Sometimes in lead 2, 3 and AVF also they may be seen, but they are narrow and they are usually very small in amplitude. Now, associated with analysis of the QRS complex, you're going to look at the R wave progression in the chest leads. So we look at them from the chest leads from V1 to V6. Now the left ventricle is larger. So as the R waves, we move from V1 to V6, the R waves tend to get larger and the S waves normally tend to get smaller. And the lead at which R wave becomes equal in amplitude to the S wave is known as the transition zone. And usually this transition occurs at V3 or V4. Sometimes the transition takes place after V4, and this is when we label it as poor progression of R waves or as late transition. For example, look at this ECG. We see that the R wave is getting progressively larger as we move from V1 to V6. But look at V3, we see the transition zone where the S wave and the R wave are finally of the same height. And this is called a normal transition or normal progression of R waves. Look at this ECG. V1, V2, V3, we hardly see any R waves. V4 also, it's not there. And then suddenly in V5, we see the R wave. So probably somewhere between V4 and V5 is where the transition took place, and this is the transition zone, and that's a later transition of the R wave. Now in the ST segment, where normally the ST segment is isoelectric, that is, it's on the baseline, and you can have deviations of up to 1 millimeter, and that could be considered normal. Now why is it important, ST segment? Because ST segment elevations and depressions may be a sign of ischemic heart disease. In fact, in the emergency room, someone comes with chest pain, we're often tempted to immediately look onto the ST segment because that's what usually indicates if this person is having an acute coronary syndrome. So an ST elevation in its appropriate setting should always be considered as a feature of acute myocardial infarction unless proven other ways. This is because the ST elevation can be of different shapes and may vary as the infarction progresses. But at the same time, we need to understand that even normal individuals can sometimes have phenomena like early repolarization, J-point elevation, where you can have an ST segment elevation which can be confused for an acute coronary syndrome. Now look at this ECG. Here we see this is a normal ECG where we see that the ST is there isoelectric right at the baseline. Now look at this ECG. Look at where the baseline is and look at where the ST segment is. This is called ST depression. How about this ECG? That's where your baseline is. You can clearly see the ST segment is elevated. So normally what do we observe in the T wave? So first of all, we are going to look at orientation. Is the T wave upright or is it inverted? Now generally as a rule, the T wave follows the direction of the QRS complex. So if the QRS is negative, predominantly negative, you could expect the T wave to be negative as well. For example, in lead AVR, where the QRS is usually negative, the T wave is usually negative as well. The same time, in leads 2 and V3 to V6, the T wave is normally always upright. So if you see negative T waves in lead 2 or V3 to V6, they are abnormal T waves. But in all other leads, the T wave could be normally negative, isoelectric or positive. So we cannot clearly say whether the T waves in these leads are negative, isoelectric or positive. But there is a clue. Now say that lead V2 has an upright T wave, then all the leads to the left of that means V3 to V6, should normally have upright T waves. Now say you have an upright T wave in V1, then you would expect V2 up to V6 to be positive. So if V1 is positive and V2 has a negative T wave, that could be labeled as abnormal. Then we look for any standout morphology in the T wave. Tall T waves, for example, are seen in hyperkalemia and in hyperacute MI. You could have a symmetrical T wave inversion or biphasic T waves, which could be seen in acute coronary syndromes. So here are some examples. Here we see a normal ECG, and notice in ABR you have normal inverted T waves. In AVF there is a normal T wave that we can observe. Now look at this ECG of someone with acute coronary syndrome. We see the symmetrical T wave inversions. Here's a patient with a hyperacute MI. We see the tall T waves. And here's a classical patient with hyperkalemia. Hyperkalemia, we see the tall T waves, which might be an early sign of hyperkalemia and helps us to take intervention at an earlier stage. So, how do we calculate the QT or the QTC interval? Now, QT interval depends on the heart rate. So this is one interval which is going to vary with your heart rate. Now, if you look at this chart, we see that as the heart rate increases, the RR interval reduces. You see that? So as heart rate is increasing, the RR interval is decreasing. And similarly, there is a corresponding reduction in the upper limit of the normal QT interval. So as the RR interval increases, the QT interval also normally increases. So we know as RR interval increases, the heart rate decreases. So you see that it's not fixed, the normal range is not fixed. Now it's going to be difficult to remember this chart and for every value of your heart rate to know the corresponding QT interval. That's why to make it constant, we have something called the corrected QT interval. Now we use this corrected QT interval so that you just have a constant value for the QT interval. So corrected QT interval, also known as QTC, is the measured QT interval divided by the square root of the RR interval, where both are in seconds. So the normal range, now you have just one constant value to remember. The QTC is 0.33 to 0.44 seconds. Now this formula is not 100% foolproof, and as we go to extremities of heart rates, you can have an inaccuracy in this formula as well. So let's try to calculate the QTC in the following ECG. There you have your QT interval is, you got 9 small squares into 0.04, and you get 0.36 seconds. The RR interval is 18 into 0.04 and you get 0.72 seconds. So when you calculate it, do the calculation, you're going to get 0.42 seconds. So now the problem in, especially if you're in an examination hall, is how do you calculate the square root of your RR interval? It's going to be pretty difficult, especially with the shortage of time. So usually the examiner might just insist on you knowing the formula and not actually doing the corrected QTC. So what to look for in the U wave? Now this is the last phase of ventricular repolarization. We just observe, is it present or is it absent? So normally it is absent, but presence is not confirmatory of abnormality. However, it may be an evidence of hypokalemia. So there you see the example of a U wave. So there we have it. We have done the 12 steps in approaching an ECG. We'll just go over it again. We're going to basically move in a general direction from left to right. We start with calibration, then you look at rhythm, then you follow that, look at the heart rate, calculate the heart rate, then you calculate the mean QRS axis, then look at the P wave, the PR interval, look at the QRS complex, And associated with that, you look at the progression of the R waves, look at the ST segment, consider the T wave, the QT interval, the U wave, and then you're done. Okay, so here is a trial ECG. What you could do is you could pause the video now and try the 12 steps out on this ECG. Okay, so we see the calibration is normal, the rhythm, it's a regular rhythm, there's no irregularity. The rate, we see it's approximately 4 big squares, so 300 divided by 4, that's 75 beats per minute. The axis, if you use both the long method, you get close to 60 degrees, and again from the shortcut method also we see that both 1 and AVF are upright, so it's a normal axis. The P wave is normal in morphology, and it looks same all throughout. The PR interval is again normal, 0.12 seconds. The QRS complex, yes, it looks normal. There's a normal width if you calculate it. The height is normal, and there's no abnormal Q waves. The progression of the R waves, is normal. You see the transition taking place at V3. The ST segment is normal. There's no significant ST elevation or depression. The T wave is normal. So we see some normal T inversion in AVR 3 and V1. As I said, this could be normal T inversions because these are leads where you can normally have negative or inverted T waves. The QT interval is normal, 0.36. So as I said, in an examination, or if you're if you don't have any doubt that the QT looks prolonged, you could just leave it at QT, or you calculate the QTC interval. Finally, the U wave is present on some of the chest leads. You could see it clearly in V2 and V3. I hope you got some idea as to how we approach an ECG. Keep applying these steps that you have learned to the ECGs that you read. I know in the beginning it might appear to be time consuming, but as you keep practicing these steps, they'll become second nature to you. And it's important that we apply these steps so that we don't miss important findings. In the coming tutorials, we're going to start dealing with specific situations, specific problems in the ECG. So if you'd like to see more tutorials like this, please do subscribe and hit the notification bell. So till the next time, bye-bye.